Good morning, everybody. My name is Pradeep Chopra. I'm a pain medicine specialist in Rhode Island. I teach at the Brown Medical School. Quick introduction, I did my training and fellowship in pain medicine, and I teach at the Brown Medical School. This is a standard disclosure and disclaimer, no financial interest or potential conflict. So the way I look at EDS as, I think of it as a normal variant of the human anatomy. I don't consider it to be a disease. It's, we have tall people, we have short people, we have big people, we have small people, dark skinned people, fair skinned people. And each of these segments have their own medical problems. And I think EDS is just one of them. So the question comes up, how do you treat EDS? Well, you don't treat EDS. You don't treat a tall person, or you don't treat a short person. You don't treat EDS. You treat the problem from EDS or the specific issue from it, and some of them may not have any problems. So I'm here to talk about pain in EDS, and this is a very broad subject. So I've tried to limit it to some specific headings. Head and neck, and Dr. Kobe and Dr. Henderson have done an excellent job with that. But other reason for pain is myofascial pain, which is known as muscle pain. Then you have neuropathic pain, which is pain from the nerves themselves. A new component that we are now beginning to discover is nerve entrapment. So we have subluxating joints that are actually tapping on these joints. They're actually pinching and unpinching these joints. Then you have the standard joint pain, and then pain from organs or visceral pain and fatigue. So one of the things to remember is, I apologize for the spelling, but there is no one specific modality that's going to fix pain. You have to take different components and treat one of each, hope to expect a small percentage of relief from them. For example, if you start a drug, say gabapentin, expect some relief from it. You add physical therapy to it, expect some relief from that. And so each one of these adds on till you can get at least about 50% of function. And that's what we are looking for, is function. The most important thing about joint pain or pain in patients with EDS is proprioception, which is otherwise known as joint position sense. Is the body's ability to sense movement of the joints and their position. So what happens is, when we walk, so when I walk, my joints know exactly where I am. They send a signal to my brain, letting them know where they are. And that helps me balance, it helps me protect my bones, it helps me protect my joints, and it also helps me walk without worrying about where I'm stepping. The problem in EDS is that they have poor proprioception. They lose that. They are often very uncoordinated. They are very clumsy. They often trip and fall a lot, which adds to the problem of damaging joints and muscles. So it's really important to work on improving proprioception. And EDSers have to learn how to protect and avoid injury by not overextending their joints, by being able to use them properly. So I looked at the literature and looked for how do you fix proprioception. First one is juggling. It's very nice. You take these balls, and everybody knows what juggling is. It improves reaction time, it improves spatial location. And it doesn't have to be juggling 5 balls at a time. You can take one ball and just throw it up in the air and hold on to it. The other one is using a balance board or a wobble board. It's helpful for standing, for ankles and knees, proprioception. Stoke standing is standing on one leg. That's it. So you can hold on to something in the beginning and then leave your hand, stand unsupported, and then close your eyes. That's the other way to do that. Exercise ball, you all know about exercise ball. There's a technique of exercise called the Feldenkrais method. This is a method that was actually designed for teaching proprioception, joint protection. It's not just used in patients with EDS, but also in post-operative joint surgeries in the elderly. It increases kinesthetic sense and proprioceptive self-awareness of functional movements. Aquatherapy, the reason, and you'll find this, most EDS patients love aquatherapy. The reason is that because they don't have good joint sense, they use the contact from the water on their skin to give them a feeling of where their joints are in space. And of course, it takes away, they're buoyant in the water, they'll be able to exercise much better without straining or loading their joints. Slacklining is another technique I'll show you in a minute. And all of these exercises can be done with your eyes open, and then if you want to do even better, you close your eyes. That's juggling. And as you can see, it's great for spatial movement, for your shoulders, for hands, fingers. And this is the Feldenkrais technique. It's actually a very non-stressful way of exercising, and it helps with efficient and coordinated movement. There are practitioners who practice this. If you go online, you might be able to find someone. They have a website actually with a listing. Slacklining is you use a wide tape. It has to be a little wider than this. It shouldn't be too high off the ground, obviously. And to start with, you can hold on to somebody. You can hold on to somebody and walk with you, and then as you get better at it, you can walk on your own, and then they can actually do this with their eyes closed if it's possible. There's another technique called the joint position matching, or JPM. So in this, it's a two-person exercise. The subject is blindfolded, and then another person moves the joint to a specific angle for a certain amount of time. So for example, I can be blindfolded, and somebody moves my thumb down here and then holds it for a few minutes and then brings it back to a neutral position. And then I do the same thing on my own, same level, same time. Left something here. He left something here. So there's another technique, is called compression sleeves or taping. Compression sleeves, what happens here is that this contact of this sleeve, it's not a tight compression, it's a light compression, but it provides proprioception. It provides feedback to the brain, to the exact position of the knee, again with the ankle. And you have them for wrists, hands, elbows. Athletes use it a lot. They use it again to protect their joints. You can buy them at any store. Taping is another really good technique. It not only brings the joint back into place, it also provides proprioception. Some of the useful tips for exercise is exercising in water, but not swimming. Swimming puts a strain on their back and their shoulders. Walking in water, running in water, doing jumping jacks in water. The other thing is not to hyperextend. Whatever you do, try not to hyperextend. Stay within the range of motion. Core strengthening. Core strengthening supports your back, your spine, which then supports the rest of your body. But the key thing here is to start very low, very, very low. So if you send a patient to your physical therapist, and if they say 10 pounds, 2 reps, start with half a pound, 2 reps. That's how low it should be, and then go up from there. Avoid any repetitive movement of joints. Vacuuming, raking, these are repetitive movements. Do them in short intervals. Avoid stretching, because EDS patients depend on their muscles to hold them in place. And you don't want to stretch those muscles. If you overly stretch those muscles, you've lost that protection. Gentle stretches are all right. Most EDS patients like to stretch themselves, which is fine. But having any active stretching could be risky. Avoid stretching a muscle that's in a spasm. It's only going to make the spasm worse. The first thing is you want to release that spasm and then talk about stretching. Avoid lifting weights, especially heavy ones. Avoid resistance bands, and avoid a physical therapist who has never heard of EDS. That's so critical. Now, it's a good idea to put down what you want specifically. It's just saying diagnosis EDS and sending them to a physical therapist is not going to be helpful. We need to know specifically what exactly you want done. And again, the whole concept of no pain, no gain doesn't work with EDS. It doesn't. If these patients are beginning to get pain, a certain degree of pain is all right with physical therapy or exercising. But if you're getting pain which is excruciating, it's going to make them a non-compliant, It's also going to cause more muscle spasms, which is counterproductive to what we're trying to achieve here. Fatigue is an important component in these patients, and there are lots of reasons for fatigue in patients with EDS. It's unrelated to physical activity. So for the longest time, if you look at the medical literature, they said was, oh, patients with EDS have fatigue because they're not as active and they lose their muscle tone and muscle strength. But some of the reasons is that they have poor sleep, they have non-restorative sleep, as Dr. Posenki over here will tell you. They have POTS, they're half the time they're dizzy, and POTS itself makes you weak. They depend on their muscles predominantly to hold them in position. As you all sit over here, it's your ligaments that hold you in place. For an EDS patient, they have to depend on their muscles to hold them in place. So their muscles are even working as they sit. And then we know that these patients also have polyneuropathies and myopathies. So there was a study by Vormans and his group, and they showed that they were able to prove that fatigue is unrelated to physical activity. These patients have axonal sensory polyneuropathy. They have myopathies, and then they have abnormalities in their muscle extracellular matrix. And it puts the force of transmission between these muscles off. So we have good reason to believe that EDS patients have fatigue unrelated to their exercise or their activity. Muscle pain or myofascial pain can be really brutal. It's actually, muscle pain is worse than any pain most people feel. What happens is that when a muscle works like going in and out. That's how it works. So this is a contracted muscle, this is a stretched muscle, and that's how it works. Sometimes what happens if there are extraordinary forces or unbalanced forces, this muscle goes in and locks up, or a part of the muscle will go in and lock up, what we call as knots. But these are really hyper-irritable spots in the muscle. They're called trigger points. When a trigger point develops, one of the theories behind trigger points is that there's micro tears. Micro tears release intracellular calcium. Intracellular calcium in turn promotes more contraction, and so it goes on. They develop ischemia in that region, and it increases local chemical inflammatory mediators. So there's a soup of chemical inflammatory mediators there. There's no blood flow in there, and that is enough to cause severe pain in these patients. The problem is that muscle pain can spread, and I'll show you in a few cases how it spreads. So the way to treat muscle pain is to treat the cause first. Is it a joint subluxation? Is it posture? Is it repetitive use? So the first thing is to treat that. And then you can consider other modalities like trigger point injections or dry needling. But whatever it is, avoid excessive stretching. That's the key here, excessive. So this is a pictorial of this patient has pain in the back, in the neck, in the upper back. The trigger points are actually over here, down here. This trigger point for this side, for this area, is down here near the scapula. This one is up on the left shoulder. This patient has pain on the side of the neck or in the neck going onto the side. So they have headaches, face pain, facial pain, jaw pain. The trigger point is actually over here. This patient has back pain going down the leg. Their trigger points are over here. Now, this is not the only reason why people have pain, but this is one of the things to look at in patients with myofascial pain. A trigger point is exactly what it is. This is the trigger point. This is the way the muscle is contracted over here. There's a muscle. There's chemical inflammatory mediators here. There's a zone of local ischemia here. Stick a needle in there. You can inject. There are different kinds of injections, drugs that physicians inject, from local anesthetics to steroids. What happens is it breaks the spasm. When it breaks the spasm, they have to stretch it right after that. This is dry needling. Dry needling is a little safer to do. It's a solid needle. It's not a hollow needle. It's thinner. It causes less pain. The only thing is that the effect of a trigger point injection lasts longer than a dry needling. So dry needling is often done by some physical therapists now. Muscle relaxants are not really very helpful. I have my doubts about using them in patients with EDS. Use them very sparingly because I know these patients need their muscle tone to hold them in place. Using a muscle relaxant may not be the best idea in these. So use them very sparingly. They're good to use for bedtime, at bedtime for sleep. They do help you sleep. The only ones that are approved for long-term use are baclofen and tizanidine. Prevention. This is by far the most important thing someone with EDS can do for themselves. Prevention. And so, especially when I see kids, I'm really happy to see them is because I know I've got them before the damage is done. And the reason is that I look at ligaments like, I look at connective tissue like rope. It's flexible, it's strong, but it's not stretchable. In EDS, I look at this connective tissue as being like a rubber band. It's flexible, but it's stretchable. And if you stretch it too much, it stays stretched. And then if you stretch it too much, it'll break. You don't want to get to that point. What can we do to prevent? So the problem is when they have tissue damage, it takes a lot longer to heal. And even when it heals, it doesn't heal as strongly, which is why orthopedic surgeons try not to operate on patients with EDS. One of them is do not stand on one hip. It's like this. You don't want to stand. Don't stand on the outside of your feet. You'll see this a lot in EDS patients, kids. They like standing like that, and that damages you. Do not sleep on your stomach, especially for extended periods of time. This is very common sight to be seen with kids who sit like that. Damages a whole lot of ligaments over there. A hyperextension of the knee. It's difficult, but if you keep repeating it to your EDS patients that do not hyperextend your knee, be cautious about it. So when they're standing, they try not to hyperextend it. You can't avoid it while you're walking. That's the problem. Working at home, again, avoid repetitive activities like vacuuming, raking. Do them in short intervals, 10 minutes intervals. So for vacuum for 10 minutes, then go do something else. For women, kitchen counters, you can elevate your work surface so they can stand up straight and they're not bent over on the kitchen. Oftentimes, you can put blocks to raise their work surface. Do not carry grocery bags in one hand, especially heavy ones, of course. Use a shopping trolley, use wheels wherever you can. Keep your handbags light, because this is what happens if you have a heavy handbag. Look at all the joints, the spine, the ribs, the lower back, the hip, the knee, the ankle. You're straining all of them. Headache and neck pain, it's been well covered, so I'm just going to go briefly over that. So I counted, there are 14 reasons for headache and neck pain specifically in patients with EDS. I think there are more actually, but I left out some of the gory ones. Dr. Henderson really talked very nicely about Chiari malformation. Cervicogenic headaches are from muscles. TMJ pain, or what's known as craniofacial pain, is a really significant reason for pain in patients with EDS. Actually, it's a very significant reason for headaches in patients without EDS also. Vision, EDS patients have a slew of vision issues, a slew of them. And almost all of them have some vision issues that have to be corrected. Orthostatic intolerance, POTS is a very common reason for headaches in these patients. Tethered cord syndrome, trigeminal neuralgia, spontaneous CSF leak. This is a hard one to diagnose and even more difficult to treat. But it is actually a very common reason for headaches in this group of patients. Craniocervical instability, atlantoaxial hypermobility, these are again very common reasons. Cervical facet joint arthritis, like joints everywhere. These patients are prone to developing arthritis in their cervical facets. Occipital neuralgia. What did I do? Antidepressant. So these are some of the iatrogenic reasons. Rebound headaches. If they've been on headache medications for too long or too much of it can cause rebound headaches. It's a very difficult situation to treat. Migraines, and then of course stress. I just want to connect the dots over here. So if you look at some of the symptoms from lower brainstem symptoms in patients with Chiari malformation, you'll see that these are the same symptoms that happen from other conditions that patients with EDS have. For example, mast cell activation disorder, gastroparesis, POTS, nausea, dysphagia, throat tightness, sleep apnea, shortness of breath, palpitations, face pain, double vision, or syncope. So patients with EDS, they present with the same symptoms for multiple different reasons, and it's really hard to tease out which one is the one that's the most prominent one. And it could be all of them, or it could be a few of them together. Neck pain. So if you look at this chin poking, I call this a chin poking posture. We tend to do that a lot, especially with computer usage now. We tend to do that. We stick our neck out. Why would I stick my neck out? Because one, I think it's a comfortable position. It's one, because I forget. The next one is because I have bad vision. I'm trying to, and like I said, poor vision is in EDS is really, really a prominent feature, as Dr. Singman will tell you. That can cause headaches, neck pain, and back pain. And of course, fixing the posture, you want the scapula in line with your pelvis. You want your chin back to your sternum, square your shoulders. So again, looking at this poking chin posture, this pictorial over here, you can see this, it'll present as neck pain, headaches, face pain, and even back pain. It can even go down to back pain. I just listed a very small list of vision issues in EDS patients. Keratoconus, where the cornea is cone-shaped, astigmatism, glaucoma, lens displacement, which is a little more common in the Marfan's, retinal detachment, asymmetric eyeball size, dry eyes, POTS can do this also, can cause blurry vision. So we're seeing a pattern over here where different things, for example, vision can cause headaches and neck pain, Chiari malformation, cervical instability, all these cause headaches and neck pain. And it's our job to figure out which one is to tease out all these issues. What happens is, when you're in this forward head position or the poking chin posture, it shortens the extensor muscles. So this group of muscles becomes shorter. The flexor muscles become weak. So this is my solution. You stick a Post-it note on your computer screen, a blank Post-it note. The reason is that if you write anything on it, then you ignore it. Every time you look at a blank Post-it note, you're going to say, why is it blank? And then you say, oh, I need to fix my posture. So it's like a painting on the wall. You don't look at the painting on the wall, but if you have an empty frame on the wall, you're going to say, hey, what happened to that? So this is my very wonderful nurse, Cherish, and she volunteered to pose for this. And as you can see, she's trying to show you a chin poking posture. And then the simplest treatment is to put your finger over here. So this is my posture, and you push your head back. Put a finger over here on the chin and push it back. And that's what this Post-it note is supposed to remind you. So a blank Post-it note. We know, the neck has facet joints on both sides. We do know that the C3, C4, and the C5, C6 are the most hypermobile of these joints. And this is the pattern of their pain. And again, you see it's neck pain and upper back pain. So connecting the dots, neck pain and upper back pain can come from cervical instability. Chiari can come from myofascial pain, can come from cervical facet joint pain. And all of these can contribute to this pain. I would caution using steroid injections. I just worry about using steroid injections in patients with Ehlers-Danlos syndrome. One technique is to consider radiofrequency ablation. Neck strengthening exercise is key over here. Whether you do the shots or not, neck strengthening is the most important thing. Posture correction, and of course, avoid hyperextending or over-rotation of the head and neck. This is a not so common reason, just wanted to bring it up. Type 3, type 4 EDS patients, you would see head and neck pain. Be very, very careful with manual physical therapy, because they could wind up with, they might have a cervical artery dissection. and you can see how the cervical artery is dissecting over here, and any kind of manual therapy in these patients is dangerous.
Not any, the vigorous.
The vigorous kind. The vigorous kind, right, exactly. So temporomandibular joint dysfunction is present in about 70% of these patients. Avoid excessive mouth opening, taking large bites, especially if you're eating something hard like an apple. Caution when yawning. This is important. To see an orthodontist who's really good with temporomandibular joint pain, it's not as simple as putting a mouth guard. A mouth guard is just going to protect your teeth. It's not going to prevent you from grinding and chewing. And these are the symptoms you can see: diffuse headache, neck pain, going into the face. Again, the triggers are over here. There are triggers in the masseter muscle, the temporalis muscle. So again, we've come across another reason for headaches and neck pain in patients with EDS. So going down, let's go to the wrist and fingers. This brings me back to proprioception again. When you hold a pen, it has to be tight enough, not too tight, not too loose. What happens is these patients don't quite figure out how tight they should hold a pen. And in fact, some kids will hold it like this, and some hold it like this. But what happens is we overcompensate by holding it too tight. And if you overcompensate it by holding it too tight, eventually it's the first CMC joint, the first carpometacarpal joint that gets worn out. It's this joint over here that gets worn out. The trick is you want to splint it, but you don't want to splint it to restrict the movement too much. So silver splints are a great idea to go with that. They allow a certain degree of movement, but they don't completely restrict movement there. A compression glove, a compression fingerless glove, again provides proprioception. And the best one is to take some foam tape and wrap it around a pen, make it thick enough. It helps with proprioception exercises as well as prevents damage to the first CMC joint. Topicals, ointment, lotions, and patches. I like using topical NSAIDs. They work really well as compared to oral. They do work. Orals have their own risk. You're not looking at as many risks with the topicals. We're now beginning to find that topical cannabis works well even for neuropathic pain. It's a real surprise. I have patients now coming back and telling me topical cannabis works well. The advantage is that you don't get the side effects. Whatever you order from a compounding pharmacy for a topical, make sure they have a carrier agent on the lines of DMSO or Lipoderm or Active Max, because these are the drugs. There's no point in putting an active drug on your skin if it's not going to penetrate, and these are the drugs that help it penetrate. So I really like to see this mentioned in my prescription, asking that it should be mixed in one of these. There are some commercially available one. Pensid has DMSO with diclofenic acid in it. Voltaren doesn't have DMSO in it. Flector patch is also diclofenic. Lidocaine patches are not really helpful. This is by far the most important joint in the body, feet, because if these patients have any feet or ankle issues, it's going to reflect on their knees, which is going to reflect on their hips, reflect on their backs. So this is the first thing I always insist on talking to patients with EDS is about their feet, how to take care of them. One of the exercises you can do is barefoot walking. It helps where it's safe and comfortable, of course. It helps with conditioning of muscles. It helps with proprioception. Another exercise they can do is rising on their tiptoes and then lowering themselves gently, but descend in a very slow, controlled way. Footwear. It helps with unstable ankles, hypermobile feet. Heels are a bad idea. Sandals are a bad idea. You have to have something that has a fastening over the midsole to better protect it. So if this is my foot, I need a shoe that will hold it, sandwich the two together, and for that you need to have laces in the middle. So in the midfoot, you have to have fastenings over there. If you have shoes that you really want to wear, then try shoe inserts. The thing about shoe inserts is, be very careful which kind of shoe insert. It should have a cup for the heel. It should have a contour to hold the arch in there. and it should be made of solid material, not soft, because soft material changes shape. So you want a heel cup for stabilizing it, a contoured shell, and you can even get wedges. They have wedges over here that actually you can start with a small one and then go to a higher one and higher one as you progress. Ankle supports may help but should not restrict joint movement. Again, these should not be soft, they have to be made of a solid plastic material. There's one company that makes it, you can pick it up at any store, it's called WalkFit, which actually meets this criteria. Knees is again a very big issue because it's a weight loading joint. What happens is, this is the patella, this is a floating bone in front of the knee, it's connected to the leg with this group of muscles, the quadriceps groups. If they have a subluxing patella, so the patella actually swings from this side to this side. Imagine if it swings. If it swings to this side, it's going to put a strain on these muscles. If it swings to this side or laterally, it's going to put a pressure, it's going to strain the muscles on the medial side. And this is a very common reason for patients with patellar subluxation to have pain. The pain actually radiates up into the thigh, anterior thigh, and the lateral thigh. So pay particular attention to the medial and lateral quadriceps, the tensor fascia lata, which is this muscle on the side, otherwise known as the IT band. Again, manual techniques to relax and lengthen these muscles. Patellar taping is a good way to keep the patella in the middle. You can try bracing. There are lots of braces have something to hold the patella in place, but I'd rather have patellar taping. The less cumbersome you make their knees, the better it is. Nerve entrapment is something that has worried me a little bit now, because in this group of patients, nerves get entrapped between subluxing bones. And I'll show you an example. Some of the nerve entrapments for subluxing joints can be from the brachial plexus. So you have the brachial plexus, which travels over the first rib, and it lies below the clavicle. The radial nerve, which lies over the radial head over here, gets entrapped over here because the head of the radius is subluxing. And then at the knee, the peroneal nerve gets compressed because the fibula is subluxing a lot. So I'll show you an example. The tibiofibular joint is also known as the poor cousin of the knee joint. This is the joint which is on the lateral aspect of the knee. It's a little lower than that. And what happens is, we know that the tibia and the fibula are two bones that are aligned together. They form a joint on the proximal end, and then they form a joint on the distal end. These patients are now coming in with patients with EDS presenting with leg pain, pain from their knee going down their foot, pain even going up to their thigh. Oftentimes they have a subluxing tibiofibular joint. The pain is along the lateral aspect of the leg. They have knee pain, especially when they walk. They also have ankle pain. The pain is in the thigh, and it usually happens after an inversion injury to the ankle. It can happen after a torsion injury to the ankle. They may or may not have foot drop. If the peroneal nerve is getting pinched, then they may have foot drop. If it's not, then it won't show up. Oftentimes it mimics deep vein thrombosis. So this is you're looking at the knee from the side, on the lateral side. That's the fibula. That's the common peroneal nerve that winds around the neck of the fibula. And you can see in this torsional injury to the knee or ankle, the patient, there's a torsional injury, especially in sports injuries, this is very common. And this is the peroneal nerve that winds around the neck of the fibula over here, and it goes down to the leg, especially to the lateral side of the leg. The tip of the fibula connects the IT band. So if this bone moves out, if the fibula moves out, it pulls on the IT band also. So because of the bone shifting, they get muscle pain down their leg, below the knee. They have knee pain. They have pain because the IT band is being pulled. They have pain from the IT band over there. And then they have features of peroneal neuralgia. So this is an X-ray at rest without any stress, and this is with stress. And you can see how the fibula has shifted over here. This is another one. It's in a normal reduced position, When you put weight on it, when you stand on it, the fibula moves out. It's just a dynamic shifting of these joints. And the peroneal nerve lives right here. So whenever this gets dislocated, it actually pushes on the peroneal nerve. This is another pictorial. You can see this. This is the normal right side, uninjured. You can see how the fibula has shifted out over here. When it shifts out, it pulls on the IT band over here. It pulls on the muscles in this area. The common peroneal nerve gets pinched. I tried looking for imaging in these patients, and this is the best I could come up with. It's actually 6 X-rays, AP, lateral, oblique, in the normal and stressed position, which is standing, and then it has to be done on both sides. This is a bad idea. Screw fixation, one, because EDS patients have osteopenia. They don't really like hardware stuck into their mobile joints. You want some mobility at this joint. There has to be some mobility at this joint. The best thing to do is an allograft or a bone matrix with putty. Sometimes surgeons may actually put in a screw temporarily to allow the allograft to heal, and then they take it out later on, which is fine. So we talked about pain from normal healthy nerves that are being squeezed. Let's talk about pain from nerve damage itself, neuropathic pain. We don't exactly know why patients with EDS have neuropathic pain, and there are several theories. One is that nerve connective tissue is more fragile. These nerves cross over hypermobile joints. So when it crosses over a hypermobile joint, the nerve is getting pushed and pulled again and again, and it might cause damage to them. Some of them actually present with small fiber neuropathy. And then we have a group of patients with complex regional pain syndrome. What is complex regional pain syndrome? It's a horrible, painful condition that is, the pain is disproportionate to the usual cause of the trauma. It can happen after a minor trauma, or it can happen after surgery. Cannot be explained by any other medical condition. I'm not quite sure if that's a good diagnostic point, because oftentimes we do have a reason, but the pain is far more severe than expected. There's pain to touch, what we know as allodynia. It could be dysesthesias. There's swelling, there's skin and hair changes. They have temperature asymmetry, so the affected side might be colder than the unaffected side. They have color asymmetry, and then they have muscle symptoms. This is a picture, and you can see this hand is red compared to this hand. You can see some swelling on the left side. This, you can see some nail changes. The nails are distorted, they are discolored. This foot is redder, is darker in color. There's some swelling you can see over here. There's some dystonias over here. This is a fixed flexion dystonias to the ring finger and the pinky finger on both sides. And he had RSD on the right side. This is, again, you can see the nails are distorted, they're discolored, and they break easily. Another one, you can see the difference in color, you can see the swelling. Imaging is not, there are really no good tests for testing CRPS. There are all kinds of tests out there. None of them confirm or not confirm RSD. You may want to do the test to rule out any other diagnosis. That's the only reason we want to have these tests, but they don't confirm or not confirm them. Medications. So there are a slew of medications out there, and like I said, you're looking for some benefit from one drug, some benefit from a second drug, and when added together, you can get a whole. So if you get 10% from one, 10% from another, or 10% from another, 5 different things will give you 50% relief. Gabapentin and pregabalin or Lyrica. Most of you know about it. Gabapentin is a slower acting drug. It takes weeks for us to notice a difference. Lyrica is a great drug. It's faster acting. And again, try any of these for 8 weeks. If in 8 weeks you haven't seen a remarkable difference, time to taper them off. And sometimes when you taper them off, you'll actually notice that it was helping, and then you put them back on. Tricyclic depressants, antidepressants like nortriptyline, amitriptyline, we know that well for myofascial pain as well as nerve pain. Doxepin is a good drug. It actually helps, it's even helpful for mast cell activation syndrome. It has some antihistamine properties. Selective norepinephrine release inhibitors. This is the newer class of medicines that we've been all very excited about. It elevates the norepinephrine level in the central nervous system, which helps modulate pain. Of this, there are several of them. The Savella or milnacipran is one of them. It increases the norepinephrine levels 3 times as compared to Cymbalta. NMDA antagonists like low-dose ketamine, unfortunately, this drug can only be given IV or sublingual, and then low-dose naltrexone, we'll talk about that a little bit more. Free radical scavengers, there have been studies that have come out, a lot of them from Netherlands have shown free radical scavengers for some reason help neuropathic pain a lot. Alpha lipoic acid, N-acetylcysteine, DMSO topical, vitamin C. And there's something called earthing that it's another discussion, but we can go into that later on. Other drugs that I like to use are chelated magnesium. Now, magnesium oxides and magnesium chlorides have a very poor absorption. Chelated magnesium, which is magnesium combined with an amino acid, has a very significantly higher absorption. Magnesium L-threonine is one of the magnesiums that actually crosses the blood-brain barrier. A great way to go in patients with, especially with migraines. Gluten-free diet, NSAIDs. I'm always very hesitant about using NSAIDs in Ehlers-Danlos patients. It can be used just to a certain degree, but it's best when combined with acetaminophen. So an NSAID with acetaminophen is actually 1 + 1 is equal to 4. It potentiates the action of the NSAIDs, but you can also use them topically. Things to avoid are opioids, especially in higher doses. Opioids in higher doses can cause opioid hyperalgesia. These patients present with more pain, especially neuropathic pain. Avoid anything that involves zapping somebody with electricity except a TENS unit. Psychiatric treatment for pain, I don't really like that. It's okay if you have depression for treatment of depression or anxiety, but not for the treatment of pain. So be very specific. When I send my patient for behavioral treatment, I'm very specific. I don't want you to worry about the pain. I want you to worry about the depression or anxiety. This is a key concept in understanding chronic pain. So what happens is, when in central sensitization, briefly I'll explain to you. If I stick a pin in my finger, the pain signal, an electrical signal, travels up. It's not painful yet. As soon as it travels up into my brain, it gets a meaning. And that's when I feel the pain. That's when I suffer from pain. So what I do is, the brain then sends out signals that act to my right hand, pulls a pin out, sends a signal to my vocal cords, and all sorts of things happen. So there are lots of signals going down. And then I rub it, the signal goes away, and everybody goes back to their own business. In central sensitization, there's a barrage of signals. So this pain from my left hand is constant, 24 hours, 7 days of the week. So there's a barrage of signals coming in from the peripheral nociceptors. This barrage alters the strength of the synaptic connections between the neurons in the spinal cord. What happens is, when it does that, so the central nervous system becomes sensitized. So any non-noxious stimulus now becomes painful, and these patients will present with pain to simple touch. This is the key to understanding chronic pain. This is what's happening. And the culprit here is over here, the glial cells. We know that the central nervous system, 70% of the central nervous system is made up of glial cells. Their job is to perform immune surveillance under basal conditions. When they get activated, they release pro-inflammatory cytokines. These are chemicals that cause inflammation of the nerves. These substances, so the glia release a variety of substances. They are pro-inflammatory cytokines, chemokines, which in turn cause neuroinflammation. So the important thing here to see is that our understanding of chronic pain has shifted from nerves to cells. It's no longer a nerve or electrical issue. It's more of a cellular issue now. There's the receptors. These are the toll-like receptors, TLR4. They are predominantly expressed by the microglia. And under neuroinflammatory conditions, these TLR4 are upregulated. And this is the key to glial cell activation. The thing is that in opioids, and I said why opioids are not good for neuropathic pain is because opioids cause glial cell activation by acting on the TLR4 receptors. On the flip side, if you were to block these TLR4 receptors using antagonists like naltrexone, you actually decrease or block TLR4 signaling. So that brings me to this drug, low-dose naltrexone. Naltrexone, as you know, has been around for 30, 40 years for the treatment of alcohol and heroin addiction. Some years ago, and most of it is anecdotal reports, where they've seen that used in lower doses, it can actually help with some of these autoimmune conditions. So we started using them for our CRPS patients because we think that CRPS is an autoimmune condition. And I was starting to see some great results with our CRPS patients. And then I had patients with EDS who had CRPS, and they were coming back and saying that their EDS symptoms were getting better. And I was very specific, like, are you talking about pain? Are you talking about EDS symptoms? And they were very clear, no, it's different. So if you look at the literature, we're not quite sure about the exact mechanism of action, but there are three theories. One theory is the most popular one is because it's such a low dose, it transiently blocks the opioid receptor. And so by a positive feedback mechanism, it produces more endorphins. And we know that endorphins are very powerful chemicals that help with pain. Low-dose naltrexone also increases production of what's called the opioid growth factor. It increases the number and density of the OGF receptors, which help in healing and tissue repair. They also, the other theory is that it is mediated by blocking the TLR4 receptors. But we really don't have any conclusive evidence on what exactly is the mechanism of LDN. The dose usually varies anywhere from 1.75 to 4.5 milligrams. I've sometimes gone higher on this, 6 to 8 milligrams. Some physicians actually go up to 12 milligrams. As long as you stay within the low dose range, I think it's all right.
Per day or per dose?
Per day. Because it increases, so the question is, when do you take it, in the morning or at night? So one of the initial papers that came out said that you take it at night because endorphins are released predominantly at night. But now they say that you can take it at any time of the day. I start them in the morning, and then after a week or two, I have them take it at night. It may cause insomnia, it might cause mild headaches, but this is all initially. But what patients report is increased physical activity. Their flare-ups are not as bad, and when they do get a flare-up, it comes down faster. The caveat being that you avoid all opioids or tramadol. Now, if a patient is on LDN and they happen to have an emergency and have to be in the emergency room, they need to be given morphine or an opioid IV, it's all right. It doesn't cause any withdrawal symptoms. Just because LDN is such a small dose, it's barely blocking any significant number of opioid receptors. So like I said, we found that LDN was beginning to help with EDS symptoms. Orthostatic intolerance, I just want to touch on this. It's not a painful condition, but it does affect functioning. Again, the definition of POTS is an increase in heart rate by 30 beats within 10 minutes of standing. It's the easiest test to do. You can do it in your office. Just do the orthostatics in your office and you will get the numbers. A standing heart rate of 120 beats per minute, but there's no significant change in the blood pressure. Patients often complain of pre-syncope, almost fainting effect. They do complain of tachycardia. The question is this related to mast cell activation syndrome? I don't know. It could be. If you look at the symptoms, brain fog, nausea, gastroparesis, chronic fatigue, headaches, it does restrict physical activity, which causes deconditioning. So it's very, very So if somebody comes in, I can't have them exercise, I can't have them do physical therapy because they have POTS and they can't function. In fact, most kids complain more about POTS than they complain about pain, actually. This is another one that has really bothered me. I don't even have a term for it. I just call it sympathetic overdrive. These patients have a their flight and fight mechanism is overdrive. It always feels like they're on the edge. They do present with non-restorative sleep. They're very restless, and they're often diagnosed with anxiety, panic disorder, PTSD, ADHD. Is it part of mast cell activation? Is it part of POTS? Hard to say. Or is it part of all of them? So we had a very wonderful talk this morning on mast cells. I just wanted to bring it up because this is something that really affects the overall functioning of patients with EDS. They're now talking about a new clinical disorder, which is the non-clonal mast cell activation. Patients with this exhibit signs, all the signs and symptoms of mast cell, but they don't have any mast cell clonality or any obvious allergic phenomena. The mechanism by which these mast cells are activated is unknown. Like we talked about it this morning, one of them was cold. Oftentimes they'll tell you that when they come out of a shower, they notice this a lot more. But the thing to remember is narcotics, NSAIDs, alcohol can cause mast cell activation syndrome to get worse. So the triggers that we know, you have to work on that. It is, of course, distinct from idiopathic anaphylaxis because it has its own diagnostic criteria. Some of the symptoms, and actually if you look at the literature, there's a slew of symptoms. I just touched on some of the more important ones. They have the flushing, the dermatographism, abdominal pain, and the ones that are underlined are actually symptoms shared with other conditions like POTS, abdominal pain, diarrhea, gastroparesis. They do have symptoms of wheezing and shortness of breath, nasal congestion, itchy, headaches, and poor concentration. Now, are these patients having headaches from craniocervical instability, neck pain, myofascial pain? Is it mast cell? Is it POTS? I don't know. Is it all of them? That's what we need to sit down today and decide. Are all of these together? Temperature instability. Again, temperature instability is a feature of POTS, of orthostatic intolerance. But it's also a feature of mast cell activation syndrome. They have multiple chemical sensitivities. Invariably, this is one of the key questions we ask our patients. Are you very sensitive? And there's a whole list of drugs that they're sensitive to. And as I said this morning, I worry about the fillers. Are those fillers the problem? And we've seen this again and again. I'll have these patients go on to a compounding pharmacy, take out all the fillers, take out all the preservatives, and we do start seeing somewhat of a response. Because remember, half these generic drugs are made by some guy sitting in his garage in India or China. And trust me, they're not what you think they are. Now, how do you know whether they are sensitive to these drugs, or is it a mast cell activation problem, or is it a true allergy? The way I look at it is, if they have, like I said, if you take gabapentin and if you feel very lethargic, then it's an effect from the active ingredient. So you can lower the dose. But if they have a bizarre reaction, like an allergic response, or they have nausea and vomiting, then it's probably because of one of the fillers in there. They do have dry eyes, difficulty focusing. That's again a feature of orthostatic intolerance, hair loss, and then they have bladder issues like interstitial cystitis. So again, as we talked this morning, the diagnosis for mast cell activation is clinical. One of the tests that I came across was a 24-hour urine prostaglandin D2 levels, N-methylhistamine. I'm not going to go too much in details about this. We talked about the baseline serum total tryptase levels, bone marrow biopsy. But the new one I wanted to mention was a bowel biopsy. Oftentimes, these patients present with gastroparesis, they've had an endoscopy or they're going to have an endoscopy, ask for a pathology specimen, ask the pathologist to do the special stains for mast cells, the c-KIT or the tryptase levels in this tissue. So it has to be asked for specifically. We know that antihistamines control diarrhea and abdominal pain in these patients. Aspirin controls flushing. Fatigue, mast cell mediators implicated in this are TNF alpha, the IL-1B and 1-beta, and the IL-6. Surprise, surprise, these are the same cytokines that are increased in CRPS. So again, is the fatigue in CRPS from this? Is it from pain? Is it from the drugs? Or is it all of them? Prostaglandin PG2 is an inflammatory mediator, lipid mediator. It is released by mast cells after a stimulus. NSAIDs inhibit this enzyme. One of the tests that can be done is a 24-hour urine PGD2 management. We talked about this morning. I'm not going to add too much to it, except amitriptyline or doxepin can help also in these patients, helping at the same time work on pain. I certainly don't recommend steroids unless it's refractory. But the caution here is usual analgesics like opioids and NSAIDs can make it worse. Look, so going back again, looking at Ehlers-Danlos syndrome, mast cell activation syndrome, orthostatic intolerance, if you connect the dots, brain fog, increased pain, tachycardia, hyperadrenergic response, gastroparesis, are all these symptoms because of Ehlers-Danlos syndrome, or is it because of all of these together? Abdominal pain is fairly common. More than half of patients will present with abdominal pain. There's symptoms of gastroparesis. They have reflux, esophagitis, gastroparesis, hiatal hernia, irritable bowel syndrome, chronic constipation, or diarrhea. So this has come up a lot now. Visceroptosis. Are these people keeping their organs where they are supposed to be? Is their large intestine sitting in their pelvis? Is the liver moving out of their place? That's the other thing to worry about. There's a Crohn's disease. They are prone to perforation of the small because the tissue again is not that strong. They are prone to perforations. Rectal evacuatory dysfunction is common to see in these patients. There's not much we can do about it. Abdominal hernias, rectocele. This is a drug. As I finish, this is one drug that I've started looking at recently. Oxytocin. Oxytocin is a neuropeptide. Is produced in the hypothalamus. I've started using it more for my chronic neuropathic pain patients, and we're starting to see some good results. There are several papers that came out of Canada actually. Rash and Dr. Campbell, they looked at these patients with fibromyalgia. I've been using it for some of my neuropathic pain patients. We're starting to see some great results. Again, not fantastic results, but good results. So if you look at the science, there's a high concentration of oxytocin receptors in the dorsal horn. And the dorsal horn also has a high concentration of nociceptive fibers. Now, we know that oxytocin influences GABAergic interneurons, resulting in presynaptic inhibitions of the A delta and the C fibers. These are the two painful fibers. So it makes sense to try using oxytocin to see if it makes a difference. Oxytocin binds. So the mechanism of action is oxytocin binds to opioid receptors. It may stimulate, like LDN, it might stimulate endogenous opioid release. It definitely decreases stress and anxiety, improves mood. Actually, it's also marketed in the market. It's actually as a love hormone. We are seeing some good results in treating CRPS. So I'm not sure if I'm still on the fence with oxytocin, but again, if it gives me 10% of a benefit, I'm okay with that. Bursitis and tenosynovitis, we ignored these, and it happens to be the minor criteria in the Brighton score. Hip pain can be because of trochanteric bursitis, knee pain because of pes answering bursitis, epicondylitis, medial and lateral, that's the tennis elbow. Decoravians is pain in the thumb, is from tenosynovitis of the extensor tendon to the thumb. There are a slew of bursitis and tendons in the body that can hurt. So it's something that we should again pay attention in terms of patients with EDS presenting with. It doesn't have to be something fancy. It could be something simple as a bursitis. Thank you.